The Human Race, brought to you by Hickory Valley Retirement.
Most children with scoliosis don't have pain. They might have an asymmetry in their hips, one higher than the other, or an asymmetry in their shoulder blades, one higher than the other. When they bend over to touch their toes, you might be able to see a curvature in the spine. That's what the pediatrician will look for when they do their physical exam. The most common kind of scoliosis is the idiopathic scoliosis that occurs in children 10 to 18 years old. They come to imaging because someone has screened them in their pediatrician's office or their school nurse, and then come for an x-ray. If that curve is greater than 10%, then they need to be followed up with x-ray every 6 months, because as they grow, of course, that progression can happen. What the ideal goal is to catch them before the progression gets to the point where they might need surgery at, say, a 40-degree curvature.
What you see behind me is where you stand to get your scoliosis imaging. That's a little different than in the past because of how much radiation you receive and how much of the spine they can see.
The technique that we use is a digital radiography, where we stitch together 3 images that allow imaging of the complete spine. The reason it's important is that it's the lowest dose that you can achieve. So it's 30% lower x-ray dose than the computed radiography and 80% lower dose than the standard film screen radiography. And since they're young and they're growing and they're getting these x-rays every 6 months, we like to keep that dose as low as we can.
So this is something that you can at least give them some relief about that.
Sure, with the lowest dose that we can possibly achieve. And it is a low dose. You know, there are patients that require much more imaging.
What do you start doing if you have a patient, you're seeing them every 6 months, and over a year you see this progression? What is the step?
Well, the next step would be, if they are up to about a 20 to 25 degree curve, bracing is often attempted to stop the progression and hopefully prevent the need for surgery. So the brace that comes to the neck and the hips to maintain, it won't really improve the curvature, but it hopefully will maintain it so that it doesn't worsen. Really, anything is better than surgery if you can avoid it, right? Because surgery has its own dangers of bleeding and infection, and then they've got hardware in their spine for life that if you can avoid that, would be the better choice, no matter, even though it's difficult.
Again, when you say idiopathic, maybe you could describe that.
Idiopathic is the medical word for no known cause. So scoliosis can be congenital from a birth defect. It can be neuromuscular from, say, cerebral palsy or muscular dystrophy. It can be degenerative, like in the elderly folks with degenerative lumbar disc disease. And then the idiopathic or no known cause is the very most common, which is the 10 to 18-year-old kids. The most common time for progression of the scoliosis is during a growth spurt. So that's, and the 6 months is not a magic number, but that's the time that we've chosen to follow up to try to catch them, before they reach the next growth spurt. I think that once they're done growing, the likelihood of the curvature progressing is close to 0. The issue would be, is their curve enough to alter their gait in such a way that they would have down the road degenerative problems in their feet or ankles or hips or spine? That would be the issue after maturity.